Great. Hi, everyone. For those of you who don't know me, I'm Vanessa Goodwill. I'm the neuropathologist who has been reading the ADRC brains, grossing, and writing up reports for them since Annie left. And me and Dave are going to present an interesting case this morning.
Thank you. And I think I know everybody here, but in case there's people online, my name is Dave Coughlin. I'm a movement disorders neurologist who works here, but I also do a fair amount of research that has neuropathology as a major component. So I have the honor and privilege of working with the good people here. And yeah, part of that role has recently been doing some of the more administrative roles in the neuropath core for the ADRC now. So I'm going to be presenting most of the clinical history, at least as much of the record as we have, as well as some of the ADRC biomarker data that was collected on this case anyway. And then Vanessa is going to go through the pathology and we'll discuss. So was a 47-year-old right-handed Hispanic man who initially presented to the clinic in March of 2020 after reporting about 7 months of changes in his cognition. And more specifically, the wife was reporting that there were problems in late 2019 when they were visiting family in Los Angeles. He was having trouble with driving. Mostly had trouble controlling the speed of his car, usually driving much slower than usual. He was becoming disoriented, having problems following instructions, and navigating areas that were normally felt to be fairly familiar to him. Earlier that year, he had begun misplacing items more frequently, telling his wife that his phone had been stolen, although he probably just lost it, it seems like. There had been some home stressors. He was very busy with his job as a university basketball coach. He was traveling kind of weekly, and that was initially attributed to some of the disorientation and problems. However, everybody got to spend a lot more time together in March of 2020 when the pandemic shutdowns happened. So she was really noticing that he actually had significant cognitive problems at that point, many more lapses in memory, and even his language was starting to be affected. He would forget recent conversations, ask the same thing again and again. Anything that was complicated or required multiple steps required a lot of assistance, which was very uncharacteristic for this high-functioning 47-year-old person. Regarding language specifically, he was speaking less. His texts and emails were shorter. He would make grammatical errors, spelling mistakes that were uncharacteristics. There was word finding problems and trouble completing sentences. It doesn't sound like he was having word substitution issues or saying sort of nonsense words. Everything was just shorter with less grammar. Unfortunately, this appeared to have impacted his work such that his contract as his job was not renewed after the 2020 season. After they looked at their finances, it was found that he had been making several mistakes, late payments, double payments, and he ceded those responsibilities to his wife at that point. There had been a change in sleep, probably for about a year. He was noted to talk in his sleep and occasionally even get up out of bed and walk around a bit too. They were living in a private residence in the San Diego area, 4 young kids, and he had achieved 17 years of education. As far as his other medical issues, he had asthma, which was well controlled and sounded fairly mild. Atrial fibrillation, had an electroablation back in 2018. He did have a mood disorder with depression, being treated with an SSRI. He did not have any history of traumatic brain injury, no stroke history, no issues with florid psychosis, and no problems with substance abuse in the past. As far as family history, there was a maternal great aunt with memory impairment much later in life in their 90s. Brother had a TBI in childhood, but really no other significant family history that would have been of note. And these were his medications at the time of his intake. And I'm kind of matching up a little bit of information from the clinical notes that I have access to and some of the ADRC assessments. He got his neurology care primarily with Kaiser Permanente, so not at UC San Diego. And because this was March of 2020, his initial neurology intake was done over the telephone. So there was no physical exam done initially because of the pandemic. But the clinical practitioner who saw him anyway said this deserves a workup. So they initially sent a handful of blood work anyway, including values here, B12, RPR for syphilis screening. They tested for West Nile and Lyme disease by blood testing, basically everything looking normal and negative. Also had an EEG, an electroencephalogram, looking for subclinical seizures. At that point, they had a standard 20-minute short recording, which was normal. And they caught some drowsiness and sleep, which is what we like to do on our routine EEGs when possible. So went on to get a brain MRI, which kind of small, but in short was read as normal. No atrophy patterns, no significant small vessel disease, no major strokes, no iron deposition. But this was followed shortly up with an FDG PET, which was very much abnormal anyway. And there were significant decreases in glucose metabolism in several areas, right side being more affected than left in general, temporal and parietal especially hit, right frontal hit, but also a lot of posterior glucose hypometabolism too. Basal ganglia looked okay, actually. Hippocampus looked okay. And generally, this was interpreted as being consistent with a neurodegenerative disorder, most consistent with dementia with Lewy bodies, the posterior predominant, hippocampal sparing aspect. So as far as his clinical course, he stopped driving a couple of months after his initial evaluation at the request of his doctor. He just has more and more trouble in a fairly rapid succession. He's basically taking his own medications, but having more trouble remembering what he's taking and when. Was having more difficult with some basic household chores, stuff like making the bed and loading the dishwasher. He would make mistakes. Some simple things he could do anyway. But technology was becoming more of a problem, using the computer, using the phone, being able to log in and access apps anyway, much more problematic than it used to be. Behavior was changing a little bit. He was more cranky, irritable, agitated, seemed to be more withdrawn, and a bit disinhibited as well anyway. And kind of part of this was that he was very embarrassed, it sounds like, from the notes. Regarding his cognitive decline, he really withdrew and refused to tell friends or family about it. He was even getting a little bit paranoid and kind of accusing the wife a little bit of, hey, you don't tell anybody what's going on with me. Like, I don't want this shared. Clinically, he was initially treated with donepezil, which was felt to be mildly helpful for some of the aspects of memory, but was eventually switched to memantine for reasons I couldn't quite tell. Seroquel, about 25 milligrams, was added at nighttime for evening agitation. But generally, this was felt to be fairly rapid. I mean, this was the person who was a high-functioning university basketball coach who was 47 years old, who went from being pretty normal to being pretty darn demented anyway within the course of probably a year and a half. So this triggered something that we do on the clinical side with some degree of regularity, a rapidly progressive dementia workup anyway, which includes a little bit of a broader workup, including a lumbar puncture. Now, this is a pretty good looking lumbar puncture at all. There's no white cells of note. There's a pretty clean tap with only 16 reds in the fourth tube, normal glucose protein, oligoclonal bands were negative. They sent a paraneoplastic panel to Quest, which was negative. It's not our panel of choice, perhaps, but at least should do a solid job of looking at the most common antibodies associated with paraneoplastic encephalitides. His CSF was also sent to the National Prion Disease Center in Cleveland, looking for Creutzfeldt-Jakob disease changes, and his PRNP RT-QIP was negative, so did not have evidence of prion disease on that assay. His total tau, you can see the value here in nanograms per ml, was a bit elevated anyway, higher than their upper limit, but not much. And his 1433, which is a marker of neuronal degeneration, was negative by their immunoplot assay. He ended up with a fluor beta pure amyloid PET, also done through Kaiser in 2021, which was read as positive. He had plenty of loss of gray-white contrast in mostly the posterior regions, occipital and parietal cortices, but it was kind of everywhere, it seemed like. Positive amyloid beta PET scan. His course, unfortunately, continues to be rapid. Within 2 years, he had problems recognizing his family members, including his children anyway. Visual hallucinations and illusions had crept up as well, well-formed people, animals in the home. He was disoriented overnight. Seroquel had to be increased and was eventually switched over to Depakote for more behavioral control. He was losing weight, mostly because he wasn't eating as much anyway. He had a lot of difficulty accessing PACE services, which is one of the senior organizations in San Diego. He was too young. They said he was too young, basically. Palliative care services was hard for him to access as well. He didn't have like a lot of needs as far as they're concerned, as far as pain or anxiety or hunger that they often manage anyway. He had trouble going to adult daycare services because he was too much of a handle. He was healthy, he was big, he was strong, and just would get very agitated. Depakote helped a little bit, but it sounded like it was extremely challenging for the family to work with him. He had continued worsened motor aphasia and was even noted to be cortically blind at one point in a clinical assessment in January of 2023. He had a brief episode in the hospital with a kidney stone, which sounded like it didn't require surgical intervention. He passed it on his own. He was brought to Kaiser Permanente in March of 2023, when the family was like, we can't handle him anymore. He's too agitated. And eventually he was transitioned to hospice care, and he actually passed very quickly thereafter in May of 2023. So we only have 2 years of data from him for our ADRC evaluation. Sorry if this is actually pretty darn small, but I will tell you, he entered the program in 2021 anyway. So it was about a year after his initial evaluation with the Kaiser physician anyway. At that point, his MMSE was 20, his DRS was 96, and a MoCA was 12. GDS was on the high side, 9, less than 5 being negative, and his CDR, sum of boxes, was 1. He was evaluated a year later, showing further and impressive declines, really kind of a floor effect off of many of the cognitive testing that was attempted to be done. With the ADRC evaluations, we actually do have a neurologic exam at least to look at anyway, and it was recorded as normal, aside from the mental status stuff. There was no recorded signs of Parkinsonism. There's no eye movement abnormalities. There was no note of changes in posture or gait. But to give you a little bit more of a flavor, this was his second MoCA, which was a 3. You can see really profound at this point visual spatial deficits. But to be frank, he scored poorly on every modality at that point. But especially these figure copy and clock draw signs I thought were particularly, emblematic of how difficult things had become for him anyway. As far as biomarkers goes, this participant did not have a lumbar puncture, it looks like, but did have plasma that was sampled anyway, and at both visits, and this were sent to NICRAD with these values being generated off of their Quanterix platform anyway for A beta species, p-tau, and these and serum NFL aspects too. Interestingly enough, like the A beta plasma assays anyway, it didn't look like they were abnormal if I'm understanding the cutoff values properly anyway. And also through NICRAD, he had genotyping for ApoE and he was E3, E4. I will say, I guess, as far as like diagnosis, clinically, his neurologist had assigned him several different diagnoses. Was initially called sort of early onset Alzheimer's disease that was transitioned to dementia with Lewy bodies. And then some of the last ones have basically listed a lot of different diagnoses. I don't think they were very sure. They're basically suspecting mixed pathology, AD, DLB, FTLD, PCA was even in there too. So I think this was very confusing to the clinician. As far as the ADRC was concerned, the consensus diagnosis that he held was probable Alzheimer's disease without other contributing factors.
All right, so before we look at the patient's actual pathology, I just wanted to review kind of what we routinely screen for in these ADRC brains for those of you who are not as familiar with neurodegenerative pathology. So of course, we look for evidence of Alzheimer's pathology. So that's going to include tau neurofibrillary tangles. You can see on this H&E, the big center picture, there's evidence of neuron loss and gliosis. These cells here are reactive astrocytes. And this cell with the arrow in it has a neurofibrillary tangle. So this kind of flame-shaped, looks like kind of like a ball of yarn. That's a tangle, which would stain for tau on our immunohistochemical stains. And then, of course, the counterpart for tau tangles in Alzheimer's disease is going to be beta amyloid plaques. So this is a beta amyloid stain, and you can see there's just abundant plaques throughout the neocortex here, and this will also help us pick up amyloid angiopathy. You can see these vessel walls here are staining brown with the amyloid, which is frequent in the Alzheimer's disease brains. We also look for evidence of Lewy body pathology. So The most obvious would be in the substantia nigra. So you can see on the left a gross picture of the substantia nigra in a healthy patient, which is nicely pigmented. So you get this kind of brown line versus in a Parkinson's disease patient where there's complete loss of the pigmentation grossly. And you can see it looks almost like sunken and retracted. And that's due to the neuron loss and gliosis in that region. And histologically, what that looks like is a loss of the neuromelanin-bearing neurons in the substantia nigra. So the healthy patient on the bottom left has abundant populations of these pigmented neurons versus in the images in the center, you can see there's all this neuron loss. There's a lot of dropout, and at higher power, there's a Lewy body. So this eosinophilic cytoplasmic inclusion with this halo around it that would stain for alpha-synuclein. And then we also routinely look for evidence of TDP-43 pathology. So for something like late limbic predominant age-associated TDP-43 encephalopathy or an FTLD with TDP. And it's important to know which stain you're using. There's two stains you can use to look for TDP-43. This is a total TDP-43. So nuclear staining is totally normal, and what you're looking for is nuclear to cytoplasmic translocation of the total TDP-43, which is shown with this red arrow here. And then in addition to the tau in Alzheimer's disease, you can also get tau accumulation in other pathologies. So for Pick's disease, of course, you have tau. These are Pick bodies here. You can see these have a little different morphology than the flame-shaped tangles we see in Alzheimer's. And you also see different forms of tau in like corticobasal degeneration and progressive supranuclear palsy.
So do you want to like pause for a second? So you guys have heard the story. What do you think is going on before we actually tell you the answer, I guess?
Hey, Dave. So back to the clinical history and exam and so forth. So, you know, several of the issues were consistent with Lewy body disease, as you kind of hinted, the visual hallucinations and the fluctuations, but there was no Parkinsonism. And I'm wondering why the somewhat characteristic features were kind of not put on the back burner, but their importance was reduced perhaps by how late those things appeared in what was a very rapid course. Am I right about that?
Yeah, it's a little difficult to do this because I think the quality of the clinical assessments, the history and the physical especially, suffered from the pandemic. A lot of this was done via telephone or telemedicine. But, you know, they did a pretty darn good job of assessing cognition and at least asking about some of the neurobehavioral aspects. But you're right, though, that it does have some features that would sound very consistent with Lewy body dementia anyway, at least so far as visual hallucinations, although that was a bit later than some of the cognitive impairment issues anyway. Again, there's no notes of Parkinsonism whatsoever. Fluctuations I find still personally very hard to interview for anyway, but they weren't really copying for a huge story with that anyway. There was some features that could have been suggestive of REM sleep behavior disorder anyway, with some of the acting out of the dreams, although, you know, I always have a little bit of personal hesitation without a polysomnogram because there's so many things that cause people to move around in their sleep that are not true REM sleep behavior disorder anyway. But yeah, I think that this is was a clinically difficult case because of the rapidity. And the hallucination story did not creep up until about a year after the very, very prominent cognitive issues, which were sort of multi-domain, right? Like there was executive stuff, there was memory stuff, there was language stuff, there was some hints at some sort of apractic stuff, trouble making the bed even. So we're hitting lots of areas. So yeah, I think that would have been difficult. But yeah, so DLB would have been on the list and was for the clinician anyway, too. He has biomarker evidence of amyloid pathology, at least with the Amyvid scan anyway. So there's that too. And he had an FDG PET that was read as consistent with DLB anyway.
All right, let's see what we found. So here's the gross pathology. So this is the left hemibrain. And you can see the weight here down at the bottom. The hemibrain weighed about 712 grams, which means the calculated brain weight was 1424 grams, which is pretty normal for an adult male. Between 1300 and 1500 grams would be pretty normal. So that's much heavier than a lot of the brains we see at the ADRC. But grossly, you can see there's maybe some mild cortical atrophy that's pretty global. There's a bit of widening of the sulci that was noted, particularly kind of paramedian. And it seems to involve kind of from the frontal lobes all the way back to the occipital, but pretty mild and again, a pretty hefty brain weight. So these are some of the coronal sections, and you can again see pretty nice looking cortex and underlying white matter. The ventricles do not look significantly enlarged, so there's no hydrocephalus ex vacuo really to speak of. And here's a section of hippocampus, kind of the seahorse shape down here, and it looks, again, pretty appropriately sized. There's no significant atrophy grossly of any of the major structures. And this is a section of midbrain with a substantia nigra. So it looks like here you can see some of the pigment more medially. It looks like maybe there's a bit of lateral depigmentation. This structure here is probably a vessel that just kind of got cut longitudinally in this section, but I think there's probably a little loss of pigment in the lateral portion of the substantia nigra. So that was the gross findings, and now we'll move on to the H&Es. So this is a section of middle frontal cortex, pretty low power. So you can see the leptomeninges at the top of the screen. And it looks like normal laminations, populations of neocortical neurons. There's no obvious dropout or gliosis, just from kind of this scanning low power. At higher power, again, we see nice pyramidal neurons, not significant gliosis, but we can start to pick up some plaques. So this is a little subtle, but you can see there's like a change in texture in the neuropil. So this is normal neuropil outside of the black circle. And here there's kind of this condensed pink where the texture changed. And that's a plaque. So we're picking up plaques on H&E, which oftentimes for diffuse plaques, you need a stain to see them. So the fact that we're seeing them just by the H&E already, we expect to find many more when we perform our immunohistochemistry. Cerebellum was unremarkable. It's, normal thickness of all three layers here, intact Purkinje layers, these big neurons here. Here's the posterior hippocampus. This is at a low power view. So this is the dentate, and then CA4, 3, 2, and 1. There was not, again, really significant neuron dropout here, no hippocampal sclerosis. This is a higher power view of the CA1 region in the posterior hippocampus. And again, you just see abundant pyramidal neurons. The only thing you can pick out were a few Hirano-bodies, which are these kind of pink rod-like structures. And you can see this same neuron also has some granulovacuolar degeneration, so little granules and vacuoles. Those are both kind of non-specific aging changes, but we see more of them usually in association with Alzheimer's disease in ADRC patients. So those were quite abundant, and we found a rare tangle on H&E, but we really needed the immunohistochemistry to pick up more of the tangle pathology. It was not obvious on H&E in the posterior hippocampus. And here's the substantia nigra. So if you remember grossly, we thought maybe there was a little bit of pallor laterally, and you can see that kind of in the center of this field. It looks like maybe there's a little bit of depopulation of the neurons here compared to the segments kind of at the edge of the field. And when we look at higher power, you can see multiple Lewy bodies. So here's a nice Lewy body cytoplasmic inclusion with its halo there and there. So quite a few Lewy bodies, along with some depopulation of the substantia nigra and also some extraneural neuromelanin, which we often see with that as well. And unfortunately, a few slides were missing from this case, so I couldn't show you, but there were also multiple Lewy bodies in the locus coeruleus and the pons, and then there's one here in the medulla in the dorsal motor nucleus of the vagus. So there was quite extensive Lewy bodies in the brainstem, even though the neuron loss itself wasn't that impressive. So that was all the H&Es. Now we'll go through our stains. And first we're going to look at our amyloid and tau stains to look for evidence of Alzheimer's. So the first thing we look for is the Thal phase, which is the amyloid plaque burden. So this is a beta amyloid stain from the middle frontal cortex, and you can see all these brown stains here. This is all plaques. So we have quite a few plaques in the frontal cortex. We also have abundant plaques in the basal ganglia, and there's amyloid pathology in the cerebellum. And you can see in the cerebellum, the plaque pathology is a little different. It's not as discrete and round. You often get this more like streak-like staining, but the cerebellum is kind of the last place amyloid goes. So this maxes out our Thal phase. So this would make the patient a Thal phase 5 for the amyloid plaque pathology. So now we know he's a Thal 5, but how much tau tangle pathology does he have? So here's our entorhinal cortex. So of course, the tangles usually start to accumulate in the transentorhinal cortex and then through the entorhinal cortex. And you can see here, there's these clusters of abundant tangles, all those flame-shaped structures in layer 2 of the entorhinal cortex. So they were quite abundant there, and we could also see them in the superior temporal gyrus. So again, some of these are the flame-shaped tangles, and some of the other structures that are being highlighted here are actually neuritic plaques. So the tau will highlight dystrophic neurons within the neuritic forms of the amyloid plaques. So that's helpful for another form of staging we need to do. And again, some of these slides were missing, so I couldn't show you the tau in the frontal and occipital cortex, but it was reported that there were abundant neurofibrillary tangles in both of those regions, which again is very severe Alzheimer's pathology. And if you look at our Brock staging for tau, because it's diffuse throughout the neocortex, that would give us a Brock stage of 6. And then the last part of the ABC staging is the CRAD staging, which is for neuritic plaques. So the Thal phasing we did at first was just for any type of plaque where the amyloid is, but CRAD is specific for neuritic plaques. And it's just based on the density of those plaques or the frequency. And it was felt that based on the tau staining that there were abundant neuritic plaques within the frontal cortex, which gives it a C3. So based on this, he's maxed out on all of the staging criteria. So for amyloid, for Brock, for tau, and also for neuritic plaques for CRAD. So this is, of course, going to be a high Alzheimer's disease neuropathologic change. So this is how we report that. It's a high ADNC, and then we report out the specific stages for each of those components. But is that all he has going on? We already know, just based on the H&E, that there's synuclein pathology because we saw Lewy bodies in the substantia nigra, in the locus coeruleus, and elsewhere throughout the brainstem. So we did some synuclein staining to see where else it might be accumulating. And so this is an alpha-synuclein in the entorhinal cortex. So you can see these are Lewy bodies staining the more round structures. And there's this really abundant, diffuse kind of neuritic process and granular staining throughout the background. So this is pretty severe Lewy pathology in the entorhinal cortex. And this was also noted in the middle frontal gyrus. So you can see this is, again, pretty low power. In the more superficial portions of the middle frontal gyrus, you already get a hint that there's kind of this diffuse granular kind of background staining. And then the Lewy bodies are more prominent kind of in the deeper layers of the cortex. And so this is a higher power view of the more superficial portions where you see these kind of neurite staining, these dystrophic processes with synuclein, and then the actual Lewy bodies themselves at higher power. And so this is just to show you kind of how we stage Lewy body disease. So you kind of grade it based mild, moderate, severe, or very severe based on the density of Lewy body pathology. And then depending on what sections are involved and have that alpha-synuclein, it can be either brainstem predominant, limbic predominant, or diffuse/neocortical. And ours was involved, as we just saw, throughout the neocortex in the frontal gyrus. So this was a diffuse neocortical Lewy body pathology. And then lastly, we will look for evidence of TDP43. So as I mentioned before, there's two types of stains for TDP43. This is a total TDP43. So again, nuclear staining doesn't count. You're looking for nuclear to cytoplasmic translocation. So this stain was kind of unusual. There's all this background staining. I don't see any clear cytoplasmic inclusions, but you see these kind of process-like staining, these neurites that appear to be picking up the total TDP43. So it was kind of unclear if this was an artifact, if somehow the tissue was overstained, or if this was some true kind of unusual pathology in the amygdala. So to help us figure that out, you can actually do a phospho TDP43. So when you do the phospho stain, any staining is abnormal. And here I interpreted this as negative. You can see there's some kind of light brown pigment in some of these cells, but I think that's probably just lipofuscin. So to me, with this completely negative phospho TDP43, I think this total TDP43 was probably just overstained or some sort of artifact. But it was reported as maybe a possible very early stage of late. And then this is just the total TDP43 in the posterior hippocampus. And you can see this is all nuclear staining, so no nuclear to cytoplasmic translocation. And for late, when you go from stage 1 to stage 2, it goes from the amygdala to the hippocampus. So we do not see any evidence of that in the posterior hippocampus. And there was no TDP43 observed in any other sections other than the questionable total TDP in the amygdala. So this was the final diagnosis that was reported out. It was called atypical Lewy pathology, diffuse neocortical type. And the reason it was referred to as atypical was just the degree of kind of that background granular and neuritic staining seemed a little unusual and more than what had been seen in other cases. Also, he had the high Alzheimer's disease neuropathologic change. He did have a little bit of mild amyloid angiopathy and then the possible late, but I'm not so convinced about that one. So overall, Dave did a nice job presenting the clinical. It was very unusual, very young onset with rapidly progressive dementia, and pathologically a very interesting case with multiple severe co-pathologies. So not only really high Alzheimer's disease changes, but these diffuse Lewy bodies with kind of atypical pathology and plus or minus some TDP43.
And maybe I'll mention that really the density of the Lewy pathology, particularly the neuritic pathology, was extremely impressive to Annie. I even remember her
yeah, she even showed it to Eddie Lee. She showed it around.
She called all of us to be like, what do you guys think? This is like the worst case of this I've ever seen.
Yeah.
Have you ever seen anything that looks this bad? And I mean, when she first sent me one of the slides, I was like, is this a tau stain? She's like, no, that's synuclein. I was like, oh my God, really? So yeah, and we did try to make sure that it wasn't artifactual in so much as the slides were run a couple of different times anyway, to make sure it wasn't just like overstained and with appropriate controls. And it's just really, really much worse than what we typically see anyway. So there's multiple reasons to pick this case for CPC, young onset, rapidly progressive, but also really, really impressive pathology in the setting of the brain itself actually looks quite normal as far as like atrophy patterns and weight goes, at least anyway. But the histo is really something fairly unique. So that's one of the reasons we wanted to, or many of the reasons that we wanted to talk about this. And I did want to talk a little bit about something that probably doesn't come up too much anyway, at least in the ADRC, which is the idea of the concept of rapidly progressive dementia anyway, which is something that we end up working up much more as clinicians rather than the Alzheimer's disease research platforms anyway. And I will say that the definition of what constitutes rapidly progressive dementia is a little bit imprecise and kind of depends on which papers you're reading anyway. I think most people are using sort of a 2-year cutoff from being normal to being severely demented anyway, is something that defines that class. And really, when we see this in clinic, we are usually working on sort of the middle column or everything on the right. First off, we're trying to rule out things like prion disease, trying to rule out things like inflammatory brain diseases, autoimmune encephalitis, unusual infections, very severe or sometimes just diffuse strokes anyway, or amyloid pathologies. We're asking people about toxic exposures, what they're eating anyway, if they're getting enough vitamins or something. We see Wernicke's encephalopathy fairly frequently downtown anyway. And there's a lot of other things that can make people look fairly cognitively impaired anyway over a course of a couple of months or maybe a year or two that are not neurodegenerative anyway. However, once we sort of rule some of those things out by our workup and hopefully good history and physical exam to go along with it, there are these rapidly progressive neurodegenerative disease subtypes, well described in Alzheimer's and DLB, sometimes pure, sometimes mixed, and sometimes these are people who have, indolent, regular Alzheimer's, regular DLB, who notice fairly significant drop-offs in the setting of systemic illnesses or medication changes anyway. And that's probably something that we see much more frequently on the inpatient side. Now, none of this really fits very well for this person anyway. The clinician did a very appropriate workup trying to rule out the things on the right column in the colored boxes anyway. But eventually, we ended up on the left column. But as far as time course goes, I don't totally agree with all of this. I think there are exceptions to some of these graphs anyway, but prion diseases tend to start evolving over weeks to months anyway, although I have seen a couple of cases that have taken in the 2-year range anyway to really slowly develop. Usually they have other features like a cerebellar ataxia, myoclonus, and pretty characteristic imaging findings nearly always. Inflammatory CNS disease from autoimmune conditions or infections typically will evolve a little bit faster over weeks to days. But again, that's not a must anyway. There are some more indolent versions that can progress over weeks or even like a year or two as well. I think in particular like GAD65 problems, which can be a little bit more indolent anyway. Toxic metabolic encephalopathies because of renal failure, kidney failure, medications in the setting of organ failure can be quite an issue anyway, and people can be very confused, although it tends to be in a fairly diffuse and more attention-driven fashion rather than a lot of the more specific cortical signs that this person was exhibiting anyway. But this is also a long list, but this is kind of the workup that we will do for people with rapidly progressive dementias, and it's broken up into these different big families of etiologies. This is something we go over with the residents fairly often anyway. What's the vascular etiologies of rapidly progressive dementias? What are infections that can do this? What kind of vitamin deficiencies? And you can see it goes on and on anyway. And it really demands kind of a pretty impressive and comprehensive workup. And I'd say that we do this in the hospital pretty frequently. And actually we do it a little bit more, I would say a little bit more frequently around the holidays too, which is usually what happens when family comes to visit grandma or grandpa and they're like, ooh, grandma and grandpa are really not doing as well as maybe they seem to be doing over the phone. But yeah, blood tests, lumbar punctures, imaging, and sometimes other testing for toxins is felt to be appropriate, EEG stuff too. But there's a pretty good Nature review in Nature Reviews Neurology from a couple of years ago, where Herman and Zur really tried to take a look at a lot of the cases of rapidly progressive dementia. And some of these were referred to prion disease centers, and some of them were tertiary care single center observational studies. And really what we were trying to show with this larger graph anyway, is while a fairly large proportion of them tend to truly be Creutzfeldt-Jakob disease, prion disease, there's still a fairly significant proportion, typically in the 20 to 40% range, that end up having neurodegenerative illnesses. Alzheimer's disease that progresses particularly rapidly, and we'll talk about some of the other things that can do that as well anyway.
So yeah, this is similar chart showing the breakdown of some patients with rapidly progressive dementia out of UCSF. And you can see, over half of them did end up having some sort of prion disease, but almost 40% of cases were non-prion rapidly progressive dementia. And of those, some of those were neurodegenerative. And you can see this actually breaks down the type of neurodegenerative diseases they saw leading clinically to rapidly progressive dementia. So corticobasal degeneration kind of topped the list, followed by frontotemporal dementias, but you can see dementia with Lewy bodies and Alzheimer's disease are also up there as well. And this is a different study out of Mayo, but kind of looking at the same thing where they defined it with a little longer disease duration. They said less than 4 years to include these cases as a rapidly progressive dementia over a little over a 20-year period. And they found that almost 4% of their cases in the brain bank met criteria for rapidly progressive dementia. And you can see the diagnoses of those cases here. So PSP or CBD were at the top of the list with 142 cases, and about 7.5% of CBD or PSP cases actually presenting with a rapidly progressive dementia clinical course. And Lewy body dementia and Alzheimer's disease were right under that. They had a lower number of prion disease cases, probably because those were referred elsewhere. But you can see that Lewy body disease did make both of these lists, as did AD, and we have pathology for both in this patient.
So in trying to review the literature for rapidly progressive neurodegenerative diseases like Alzheimer's, DLB, and 4R tauopathies like PSP or CBD, it's pretty tough because the definitions have changed a little bit over the years. So you have to pay a little bit of attention of how they're defining rapidly progressive. This one paper from a little while ago was estimating about 10% of Alzheimer's disease would meet their criteria of rapidly progressive. I imagine this is probably somewhat imprecise, dependent on the definition, certainly. But at least in these papers, it tends to be older people, though, more than age 70. They would suggest that probably maybe lower CSF A beta 42 and higher t-tau and 1433 levels are more associated with rapidly progressive subtypes. And it does seem like ApoE4 alleles are less or not as clearly associated with the rapidly progressive version, even though they're well-defined risk factor for kind of regular Alzheimer's disease anyway. As far as rapidly progressive DLB, Vanessa can talk a little bit more about this paper, but hallucinations and delirium were much more common early on as presenting symptoms. But again, these patients are usually described to be older. Most are older than age 70 in these case series. Pathology-wise, a minority are described as pure, as in mostly synuclein, and most actually are described as mixed pathologies, but either can occur. At least in this paper anyway, they were showing that the rapidly progressive versions of dementia with Lewy bodies at autopsy had a similar Lewy body density. And at least as far as brain synuclein seeding activity, had very similar brain seeding activities to normally the sort of the normal version of DLB anyway. And that's actually what's supposed to be shown in these bar graphs. And by the way, even though this says control, it's not like a normal brain. This is actually like a normal DLB brain of a typical long duration DLB versus the blue bars, which are the rapidly progressive DLB. And this graph is showing alpha-synuclein seeding activity from multiple areas of the brain. As far as rapidly progressive cortical basal degeneration, which is a 4R tauopathy, I think we have seen a couple cases of this. It's a bad disease already with average survival between 5 and 7 years generally, but there are some very rapid progressive cases where people pass in 2 or 3 years anyway. And when they come to autopsy, they also have a similar distribution and density of astrocytic and neuronal tau pathologies. There's probably a greater likelihood of H1H1 haplotypes, but again, that's a pretty well-known risk factor for typical cortical basal degeneration, PSP anyway. So it's a little bit tricky to piece out right now.
So this is just some additional detail on that paper looking at rapidly progressive forms of dementia with Lewy bodies. So their criteria were, again, a disease duration of less than 4 years, because there's no real consensus at this time what rapidly progressive DLB, what the cutoff should be. But even using that criteria, they identified 22 cases, and 18 of them actually had a disease duration of less than 2 years. And for their pathologic criteria, the brains had to have at least limbic predominant or diffuse neocortical Lewy body pathology. So it couldn't be brainstem only, of course. And so you can see here, as Dave kind of mentioned, that the age of onset here is much older than our patients. So it ranged between 70 and 77. And then the disease duration, some of these were pretty short. So this is in months, so between 2 and 21 months, so pretty rapid. And also clinically, some of the features, the fluctuations and visual hallucinations were much more prominent in rapidly progressive DLB than they were in CJD or rapidly progressive Alzheimer's disease. And here's just a big chart showing some more of the co-pathologies and what they found on the brain examination. So for the Lewy body pathology, 19 of the 22 cases had diffuse or neocortical Lewy bodies like we saw in our patient, where only 3 were just limbic predominant Lewy body disease. And there was a lot of concomitant pathology. So well over half of the patients, 73%, had at least intermediate or high Alzheimer's disease neuropathologic change using our ABC staging. And a small minority had only low ADNC, and then there were 2 cases that had primary age-related tauopathy. So a lot of concurrent high Alzheimer's disease changes as well in these patients. And this was the pathology that they saw. So the top panels are alpha-synuclein stains, and this is kind of more typical Lewy body pathology with some neurites in the background, but not that really diffuse, granular, really dense background staining that we noted in our case in both the entorhinal cortex and the middle frontal gyrus. And then they're also just showing some of the Alzheimer's disease pathology here on an amyloid stain. So this is kind of more typical DLB pathology. So again, just to drive the point home, our case is very rapidly progressive. We have DLB pathology with this concomitant high Alzheimer's disease change, but the alpha-synuclein pathology is fairly atypical. So we just wanted to show you some more kind of standard DLB pathology that Dave was nice enough to share. So here you can see this is from the middle frontal gyrus, some kind of scattered Lewy bodies around, but not much of that kind of background staining. And this is a little of a higher power view. So this is more of a standard case. And then if you look at our case, the density of Lewy bodies in the deeper portions is increased. And then we just have this really extensive kind of strand-like and granular staining in the background. And this is a more standard case. We're in a different area now. So this is in the entorhinal cortex. Again, you can see the Lewy bodies here. And here's another field. So you do get some of this kind of background neuritic and granular staining, but not nearly as severe as was seen in our case, which is shown here. So just very unusual and severe pathology in this patient. So part of the reason we also wanted to present this case was not only just because it's very interesting clinically, very interesting pathologically, but this patient didn't get any genetic testing. So we want to kind of crowdsource and see if anyone has any suggestions of how this case could be further worked up. And if anyone has seen anything like this before, that would be super helpful.
Yeah, I mean, it's a good opportunity to review rapidly progressive dementias in general and make the note that, a decent proportion of them are actually just neurodegenerative diseases that move along pretty fast. And it seems to me from this review of at least that version of rapidly progressive dementia, there's an awful lot that's still unknown about the risk factors that make it. And our patient here is actually pretty unusual based on what's been published before, mostly by virtue of the onset aspect of things anyway. But yeah, we're curious anyway, and that is kind of all the data we have. And yeah, genotyping and other genetic testing would be probably of interest, but if anybody has any other ideas of this, we're open for discussion.